Respected chairperson, panelists, and audiences. So, pulmonary hypertension for us cardiologists, many times we don't take it very seriously, and we are just lost in CAD and other structural disease. So first, I will talk about the updated definition, which was proposed in the 6th World Symposium on Pulmonary Hypertension in 2018. That is, mean pulmonary artery pressure should be more than 20 millimeter of mercury on invasive right heart catheterization at rest in supine position. Earlier, it was more than or equal to 25. As we know, the classification is very old one. Conventional idiopathic PH is group 1, second is due to the left heart disease, third due to the lung disease, fourth due to the pulmonary thromboembolism, and fifth due to miscellaneous causes. There are two additions in this symposium. That was, they have added two groups in group 1, subgroups, that is PH long-term responder to calcium channel blocker and PH with overt features of venous capillaries involvement. Hemodynamic definition, it is decided by mean pulmonary artery pressure, pulmonary artery wedge pressure, and PVR. If PVR is more than 3, then it is a pre-capillary or combined. If it is less than 3, it is a post-capillary. And wedge pressure, if it is less than 15, it is a pre-capillary. If more than 15, it is a combined pre and post. And the mean PA pressure, of course, should be more than 20. So how we define the acute responder to the pulmonary vasoreactivity? Generally, nitric oxide is used, and if there is a reduction of mean pulmonary artery pressure more than or equal to 10, with an absolute value of mean pulmonary artery pressure less than 40, without any decrease in cardiac output. So this is called acute pulmonary vasoreactivity that can be given calcium channel blocker. And long-term responder to CCBs are classified as the person who has given treatment remains in class 1 or 2 or comes to class 1 or 2, and there is a sustained hemodynamic improvement, at least for 1 year. So symptom, as you all know, the shortness of breath, fatigue, abdominal distension, lower extremity edema, weakness, all the features of right heart failure. There are some PH emergencies like cardiac angina, which may be due to RV ischemia and left main coronary artery compression by the enlarged pulmonary artery, and syncope. So how we approach a patient? Of course, for our cardiologists, ECG, X-ray, and echo are the baseline. And echo is many times is the predictor, or we can say which leads us to that patient might be having pulmonary artery hypertension or pulmonary hypertension. Other tests we use are pulmonary function test, sleep study, CT scan, cardiac MRI, PET, exercise testing, 6-minute walk distance test, and cardiac catheterization. So ECG, all the features of RVH with stent pattern, P pulmonary. One feature which is QTC prolongation and QRS prolongation. If there is present in a case of pulmonary hypertension, it suggests severe disease. Echo features, there are some suggestive features like RV by LV dimension, if basal dimension more than 1, or flattening of interventricular septum, PA diameter more than 25 mm, or right atrial area more than 18 centimeter square. These things pinpoint us to that the patient might be having pulmonary artery hypertension. If along with that, we measure peak tricuspid regurgitation velocity, if it is more than 2.9 or 3.4, then it is certainly, there is a high probability of having pulmonary hypertension. If less than 2.8, there is a low probability of having pulmonary hypertension. So in the management part, general measures should be taken, like patients should avoid pregnancy, vaccination with influenza and pneumococcal should be done, psychosocial support, supervised exercise training and avoiding of exertional activity, oxygen therapy for the patient having PO2 less than 60, and avoid general anesthesia, epidural anesthesia should be preferred. Supportive therapy, if there is RV failure, diuretics, long-term oxygen, oral anticoagulation in the case of IPH or pulmonary thromboembolism, we should correct anemia, and use of AC, ARB, and beta blocker, which we cardiologists often do, should be avoided unless there is a compelling indication. Vasoreactivity testing should be done, must be done, and as per the result, we should plan our treatment. First, calcium channel blocker, very old drugs, we are all familiar with this, but this should be used in a very few cases, possibly 5 to 10% cases which are vasoreactive. And we can use nifedipine, diltiazem, amlodipine depending on the heart rate. If heart rate is low, we should use nifedipine or amlodipine. If it is a initial baseline heart rate is high, then diltiazem should be adequate. Patient on calcium channel blocker must be closely supervised every 3 months, And if they are not responding, we should change the drug. We should not rely on calcium channel blocker. If patient is not getting benefit, it is a dangerous drug to be offered in the pulmonary artery hypertension. Conventional therapy, which the specific pH treatment has evolved from 1995 when IV ibuprostenol was introduced, and now till there are many drugs. More common was the sildenafil, ambrisentan, tadalafil, treprostinil, and selexipag. So there are three pathways, as we know, in the target of pulmonary artery hypertension: prostacyclin pathway, in which selexipag, iloprost, beraprost, and treprostinil are used; nitric oxide pathway, sildenafil, tadalafil, and riciguat; and endothelin receptor pathway, bosentan, ambrisentan, and macitentan. So before starting treatment, we must risk stratify. This is the most important thing, most important consensus. We must stratify patient into low risk, intermediate risk, and high risk. And then we always have target to achieve low risk status. Then combination therapy is the way forward, and in the most cases, we should use 2 or more drugs. According to the ESC classification, if the patient has no signs of right heart failure, there is no progression of symptom, no syncope, who function class is 1 or 2, 6-minute walk distance is more than 440 meter, NT-proBNP is less than 300 nanogram per, they are classified as a low risk. In comparison, if clinical signs of right heart failure are present, there is rapid progression of symptoms, syncope is present, class 4 or 6-minute walk distance is 165, or NT-proBNP is raised more than 1400, they are classified as the high risk. So this is a very important thing to do in the starting of the treatment. And second is the REVEAL-2 score, which app-based or the web-based, and there are many parameters like who, group, subgroup, demographic, comorbidity, NYHA classification, vital signs. And according to that, REVEAL score is given. If there is a low score, that is 6 or low, then 12-month mortality risk is 5% only. If there is an intermediate, 7 to 8, then 5 to 10%. If there is a high REVEAL-2 score more than 9, then greater than 10% risk of 12-month mortality. As has been shown in the study, you can see here in the curve that low risk patients are having longer survival and longer event-free period. So now starting, a patient has been diagnosed as a pulmonary hypertension, they are treatment naive. We should first, the new consensus is that should be treated in the pH expert center, which in India there are very few. And acute vasoreactive testing must be done. And after the risk stratification, if patient is low or intermediate risk or high risk, in high risk patient always IV ibuprostenol should be started first. In low or intermediate risk, we should use 2 or more drugs of oral drugs, and we should follow 3 to 6 monthly. And our target should always be to bring the patient at the low risk status. Combination therapy is the way forward. We should always tend to use 2 or more drugs. We should use 2 or more drugs. We should avoid class combination like 2 endothelin receptor antagonists or 2 phosphodiesterase inhibitors. Riciguat should be avoided with phosphodiesterase 5 as there is a high risk of hypotension, and selexipag should not be combined with prostacyclins. There are many evidences which shows the upfront combination therapy is the way forward, like by the SIT1 group for triple therapy for the severe PH, ambition trial, by the Dalto group in the Italy for the ambrisentan and tadalafil. Ambition trial is a very famous trial which used ambrisentan plus tadalafil versus ambrisentan or tadalafil. And this study showed that clinical failure is decreased by 15% and hospitalization rate by 63%. Also, REVEAL risk score also decreases with time with the treatment of this combination ambrisentan plus tadalafil, as we can see in this curve. There is another study, OPTIMA study, which studied the upfront combination of macitentan plus tadalafil, and it showed that it improves cardiovascular hemodynamics function class. PVR decreases over the treatment in the 16-week, and also the function class improves. Express study showed the benefits of macitentan with riciguat, and when it started upfront, it also showed that it achieves low risk status in the 47% of patients. Macitentan is a safer endothelin receptor antagonist as compared with bosentan and ambrisentan, as aminotransferase elevation, peripheral edema, and anemia are less as compared to the bosentan and ambrisentan. RAS reagent positively impacts RV remodeling. If it starts early, RV remodeling it prevents and it improves the RV function. Pro-BNP level also decreases and reveal 2 score also comes to the lower value. It is in this study they have published this echo finding that after 1 year of treatment of upfront triple combination, the RV function improved markedly. There are very few patients who can be started on monotherapy. Those are who are responded to acute vasoreactivity and who has been on the monotherapy for a very long term and they are stable on the low risk status. Patients is more than 75 years of age who has a risk of having side effects with the combination therapy. Also patient with the pulmonary veno-occlusive disease, because in those patients there is a chances of pulmonary edema with the combination therapy. Also patients with HIV infection with portal hypertension or uncorrected congenital heart disease. And patient who is having very mild disease on the low score. In these patients, or for some reason combination therapy is contraindicated. So we should diagnose the patient early, we should risk stratify. Risk stratification is very important and vasoreactive testing is also very important. Combination therapy is the way forward. Thank you.
Just
Yes, understood topic.
yeah. My question is that we have one molecule, you know, what we are using Selexipag nowadays. What is your comment on that?
See, I have no personal experience with this drug. But as per studies, it has been shown that it should be used with combination with either endothelin receptor blocker or phosphodiesterase 5 inhibitor, and it has shown that it works.
Selexipag was a very, very ambitious project, and now the project has been shelved. There was a multicentric trial going on involving 270 patients. But now the trial has been stopped because there was no benefit seen. The trial has been shelved. There is no benefit seen.
Okay, that's the time that we have for this presentation. Thank you, Dr. Barun Kumar. Ladies